Hello everybody, Dr. Ryan here. I'm board certified specialist internist. Thank you so much for joining me even as we talk about hepatomegaly today. If you haven't yet subscribed to my channel, I strongly encourage you to do so you don't miss any exciting content in the beautiful discipline of internal medicine. Let's go, guys. So you have a patient with a clinical problem of hepatomegaly. What are you going to do about it? Well, a nice starting point in terms of stratifying our thought process behind the possible etiologies is to ask a very important question. Is there ascites, yes or no? So if you got isolated hepatomegaly with no ascites versus isolated hepatomegaly with ascites. So let's just say you have no accompanying ascites. Then you want to ascertain whether the liver is tender on palpation. If you're dealing with a non-tender liver with no ascites and a HEPA, think about fatty liver, or is this a renal slope? Fatty liver, ask yourself, is the patient diabetic? However, if you have a tender liver in the context of isolated HEPA with no ascites, think about hepatitis. Do your investigations for hepatitis, viral hepatitis A through E, EBV, CMV, and company, right? Thinking about autoimmune hepatitis as well. Okay, if you have ascites now accompanying your HEPA, then you can have one of three possibilities. If there is peripheral edema and a pulsatile liver, you're thinking about tricuspid valve disease, tricuspid regurgitation, right, and cardiac failure. If you got ascites with a HEPA with peripheral edema but a non-pulsatile liver and an absent hepatojugular reflux, that makes you think about hepatic venous thrombus, which is Budd-Chiari syndrome. If you got ascites with a HEPA but no peripheral edema and you got a liver bruit, think about hepatocellular carcinoma or metastases to the liver. So quick fire again, everybody. You picked an isolated HEPA in your patient. If there's no ascites but you have a non-tender liver, think about fatty liver or renal slope. But you got a tender liver with no ascites, thinking about hepatitis, right? If you do have ascites with the isolated HEPA, the possibilities are cardiac failure or tricuspid regurgitation if you have peripheral edema and a pulsatile liver. Think about Budd-Chiari, which is hepatic vein thrombus, if you got ascites with HEPA with peripheral edema, a non-pulsatile liver, and an absent hepatojugular reflex. Think about hepatocellular carcinoma and liver mets when you have ascites HEPA and no peripheral edema, and you may have a liver bruit. This is how you position the patient nice and flat, supine with a pillow for the head, right? And just in terms of small revision over the different sections of the abdomen, so you can go into quadrants as we've done here, or you can divide them into 9 traditional regions, with 1 being the right hypochondrium, 3 being the left hypochondrium and the epigastrium between, 4 being the right lumbar region, 6 being the left lumbar region and the umbilical region in between, 7 being the right iliac fossa, 9 being the left iliac fossa, and 8 being the hypogastrium or the suprapubic area. Okay. Then, in terms of palpation, you want to start from the right iliac fossa. Ask the patient to breathe slowly in and out, because when the patient breathes in, the diaphragm pushes the liver down, and that's when you want to catch it. On inspiration, you go in nice and palpate deeply, right? And you remember you're observing the patient's face to see if they wince because of pain. If the liver is palpable, you want to note the following points. Firstly, size. So you measure in centimeters with the tape from the costal margin and the midclavicular line, right? So basically, normal liver span, I beg your pardon, is 7 to 12 centimeters, right? If the left lobe is enlarged, measure from the left cephaloid process. Margin should be round, smooth, or sharp. The surface, whether it's smooth or irregular, the tenderness, the consistency in terms of whether it's soft, firm, or hard, and the upper border of the liver should be normally positioned in the 5th interspace on the right from the midclavicular line. And then what you want to do is measure the span from the upper border up into the where you felt the hepatomegaly to be. A normal span is 7 to 12 centimeters. Anything larger than 12 is hepatomegaly. And then auscultate over the liver for a bruit or a rub, which is often forgotten. Please note, pulsatile liver indicates tricuspid regurgitation. And this is basically the technique. So you're starting in the right iliac fossa, ask the patient to breathe in, and you're going to feel the liver kind of against your forefinger. right? And this is determining the liver span. So we said it percuss out the upper border, right, which should be in the midclavicular line, fifth right interspace. And you measure the distance between this point and the point where you felt the liver. Anything from 7 to 12 centimeters is normal. Greater than 12 centimeters is hepatomegaly. Causes of hepatomegaly, guys, there's a whole lot of them to talk about. Okay, this is one way to certify them, right? This is taken from McLeod's. So chronic parenchymal liver disease, malignancy, right heart failure, hematological disorders, and rarities. But the way I like to do it is 3 C's, 3 I's, right? So we covered the 3 C's under the video on ascites. So it's the same 3 C's. C for carcinomatosis, speaking to hepatocellular carcinoma, lymphoma, leukemia, or maybe secondaries to the liver. C for congestion from cardiac failure. C from cirrhosis, but early on. Classically, cirrhosis gives you a small shrunken liver, but in the early phases, it can become large. I stands for infections in the way of hepatitis A through E, Epstein-Barr, and cytomegalovirus. Immune in the way of autoimmune etiologies. Autoimmune hepatitis, primary biliary cholangitis, primary sclerosing cholangitis, and then infiltrative issues like sarcoid amyloid. This is in the context of isolated hepatomegaly. We're going to be talking about hepatosplenomegaly in another video. Okay, my friends. Philippians chapter 2, verse 3, Paul says, "Let nothing be done through selfish ambition or conceit, but in lowliness of mind," or otherwise termed humility. "Let each esteem others better than himself." The Bible tells us in no uncertain terms that God resists the proud but gives grace to the humble. What we need to function effectively in this life as children of God is grace. Grace is divine enablement, and grace has a prerequisite, that is humility. So only those people who are humble will be able to access divine grace, right? And I pray that upon our lives, that we will always consider others being more significant than ourselves. I think C.S. Lewis said, being humble is not thinking less of yourself, but rather thinking of yourself less. Amen. These are my references. Have yourself a lovely day. I'll see you soon with another handy video on this series, physician examination series on my channel, Internal Medicine, Algorithms and Mnemonics. Take care.